that mentioned that work with me very closely on the learning community are Erica Palmer, who's also based here in New York, and Elizabeth Morrison, who most of you, I'm sure, know from her work in California, previously at Golden Valley. So between Eric and she's still in Modesto. So between Erica and Elizabeth and myself, we pretty much can provide support to the learning community almost like 18, 20 hours a day between the East Coast and West Coast time here. So we're really excited to be part of the project. I want to just also thank you all for your contributions to today's webinar. We really felt that it was important, this first sort of virtual meeting of all of us, to allow each of you to have a little bit of time to share what you're doing. I know we don't have enough time, but at least so you all know who's out there working on this initiative. One of the underlying themes is to really foster collaboration and build partnerships. So we want to make sure you all know who else is working on this and what's going on, so that if you need extra help or want to talk to one of your peers or colleagues about it, that you're aware of what they're doing and where they are. I do hope to have the other webinars focus a little bit more on content that you've already shared with us, some areas of interest that you have, so we will be designing those as well. But today's is really sort of a get-to-know-you call. For purposes of today, I'll be the timekeeper, because as you can see from the agenda, we have 10 groups that are going to present, so we have to really move very rapidly through them, through each of the presentations. And if it looks like you need a nudge at about the 1 minute or 2 minute mark, I'll jump on the line and do that. We have set aside some time at the end to do questions, and as Rachel mentioned, Erica will be maintaining the chat list of those questions for you. If we can't get to them today, we are going to copy them all and facilitate answering those offline. And then lastly, I just want to encourage you all to please fill out the Survey Monkey. We did send a link previously, and we'll resend it today. So if you're not logged in somehow, so we know where you are or who you are, make sure you send Erica an email as well, so we can give you the survey, because we really do want your feedback about today's webinar and future webinars. So with that, I really do want to kick it off. Elizabeth, you want to have a minute to say hello? I don't know if you're muted.
Nope, I'm here. Hi, everybody. I'm really glad that everybody's on the call and that you'll all get to hear about what everybody else is doing.
Right. And Erica, say hello. She muted. So.
Hi, I was muted. Hi, everyone.
Okay. So let's get started. We have we sent you all. Oh, and Carolina or Apana, who's with Blue Shield, are going to be facilitating the slides. So we can go ahead now and switch to the first presentation. And I believe first up is the Hank, Shasta. Well, so I know Doreen's driving. And Lynn, are you going to walk us through these slides?
I am. I'm right here.
All right, go.
Thank you. So just briefly, let me tell you what SHARC is. The Shasta Health Assessment and Redesign Collaborative has been meeting for about 5 years. It's the hospital leadership, the clinic leadership, the health department, the medical society. It's really a comprehensive collaborative to improve access and quality of health care in Shasta County. So our objective for this project is that we have historically done a pretty good job. We're not there, but we've done a pretty good job on the integration of mental health services into clinics, and we've done a terrible job on integrating substance abuse services, and not easy. So there's good reasons why we haven't. But our goal for this partnership is to improve access in the clinics and to test a variety of integration strategies, because every clinic's different. We've had success with collective accountability. The idea of SHARC actually started in 2006, and we initially, a long time ago, addressed mental health services, and that kind of created this county-wide cross-sector healthcare approach, which has only grown stronger and stronger. We once a month in Reading at 7 o'clock in the morning, and those of us who live in eastern Shasta County have to get up really early. So we've begun to trust each other. And we're sharing, the committee is sharing data on service utilization, and we'll develop some performance indicators, and it's a project that has a legs already. Our earlier emerging challenges, we're different. Each FQHC, there are 4 FQHCs in the county which essentially serve the whole county. Each provider has a different degree of behavioral health integration in place at this point. And as I said, we've made some progress on the integration of mental health services. So we have a lot of mental health patients with mental health issues. There really there's no treatment anywhere in the county that's adequate for co-occurring disorders and for those people needing substance abuse services without a co-occurring mental illness. The resources we need and the resources we can share. We certainly want to learn from this community about how other FQHCs are tackling these challenges, especially in rural settings where there are an additional set of barriers and challenges. And what we can offer is that we do have a long-term perspective on community collaborative leadership and system integration. We're excited to be here and look forward to hearing everybody else's presentation.
That was very good, Lynn, and you were under your 6 minutes. So.
All right.
You have a few minutes that others can share from you. I'm going to go ahead and hold questions, as we said, until the end, just so we don't get too far off track. But that's if others have comments about what Lynn just asked or questions, jot them down and chat them to Erica, and we'll come back to them. So let's move on to Almeida. And I'm not sure, is that Kathleen or Jennifer going to lead this one?
Yes, Jennifer, I'm on.
Okay, go ahead, Jennifer. Thank you.
Thanks. So, yeah, Jennifer Martinez. I'm here with Healthcare Services Agency, and our project is a collaboration between Healthcare Services Agency, Behavioral Healthcare Services, and the Alameda Health Consortium of community clinics here in the county. Our project really stems from a policy that Healthcare Services Agency and Behavioral Healthcare Services wrote and disseminated earlier in 2014, saying we were going to start producing reports and distributing them, noting behavioral health care utilization data of our patients that are on our county safety net program for those with remaining without health insurance, provide those reports and data to the primary care providers in hopes to enable better collaboration and coordination of care around shared patients. That was put on paper in February, but we all know it takes a lot more to put that into practice. So we're really appreciative of the opportunity with this grant to put the pieces in place to make that a reality. And working with the utilization data around our safety net program, but we're well aware that we want to lay the foundation for this to be utilized also for our Medi-Cal population in our county. So we know those numbers have grown significantly since the full implementation of the Affordable Care Act. And we're starting with disseminating behavioral health care data to the primary care providers, but our hope is also then to find a way to also share primary care data back to the behavioral health care side. So there's a really two-way part of the communication. So our explicit objectives are to put the right agreements in place to make sure we're all on the same page, the workflows, the IT pieces that are required to share data in an effective way. Our real hope and our key objective that you see there on the slide is that we would be creating a culture for routine communication between our specialty behavioral health care providers and the primary care providers. That communication between those arms of our network wouldn't just be for the occasional highly complex patient, but would be a part of our culture to have it happen really regularly whenever there's a shared patient, and communication would benefit their care. So is that all the other explicit objectives that we have in our project would really be supporting and spurring on that kind of behavior change. Really success with collaborative accountability. We do have our steering group that we've met a couple of times, but before we have really gotten into meet, we really wanted to make sure that we our assumptions for what's causing the root issues of the communication blockages that we're seeing. So we've been making this project with different components of our leadership and steering group to different stakeholder groups to make sure that we're really solving for the right thing, because we knew we could much better hold each other accountable to the work we were doing if we all really believed and trusted that we were solving the right issue, not just from our assumptions, but from what the stakeholder groups were saying back to us. So we're in that discovery and education clarifying process right now. Moving on to our early and emerging challenges, one of our components, which we thought might be a slightly simpler on the side of work and effort, has blossomed. Something that we're excited about, but what always might think are simple can often be more complex under the surface. To add to the IT components, we really wanted to identify and clarify some agreements around psychiatric medication prescriptions between primary care providers and our specialty mental health providers, making it really clear who should be initiating, monitoring, renewing prescriptions, what kind of prescriptions for what type of patients. But when we brought this part of the project to these different stakeholder groups that I mentioned, it's really clear that it's not just a medication issue, that it's really coming back to that larger communication between providers, not just perhaps an occasional misunderstanding of who's responsible for what kind of prescribing, but it's really communication about what's happening with that patient, what's the background, that then providers can really better and work together. So we thought would be a simple couple-page agreement written on paper. To clarify that, we're realizing it needs to be a couple steps back and slightly larger scope and a bargain that we can articulate between who's responsible, not just for the medication, but for responsibility for care. The resources, with that particular part of our project here, we've done some research and found some examples of kind of like memorandums of understanding between different components of a network to really clarify who's responsible for what, how does the patient transition from one part, from behavioral health to primary care and back, under what circumstances, who's responsible for what types of communication and how. But anyone in this learning community has interacted with this type of work before and has any examples of those types of agreements, we would love to look at those and see if we can build off of them. And in terms of sharing, we are really delighted to be in this kind of collaboration between Behavioral Healthcare Services and the Almeida Health Consortium. We are a county that has a number of different existing tables where we're convening different types of groups to do this kind of collaborative problem solving. So it's really in our culture to continue doing that in this type of project, and we're just happy to have the chance to really dive deeply into this particular content. So I think I'll there.
Great, Jennifer. That was really, really good. You're hitting on so many issues I know that so many of the other partnerships are struggling with, so it's going to be a really fascinating project. Let's move on to Redwood Community Health Coalition, and I'm not sure who from Redwood will be doing the lead. Is it Michelle or Mary?
Hi, this is Michelle Orstacci, and I apologize for joining late. I'm just going to need a couple of minutes to get seated, so if it's possible to go, wait for one more group to go, and then I'll be ready to present.
Okay, I think we can probably accommodate that. Why don't we slip over then to next would be the Transitions Mental Health Association. So Joel, would you be willing to go ahead and jump in now?
I am. Good morning, everyone.
Thank you.
This is Joel Derringer. I'm the project director on this project in San Luis Obispo, California. We're having technical difficulties, so we're hoping we get through that. So as I said, the lead agency on this is actually a community nonprofit group, which sort of organized as being the convener in part because it's the more neutral party. We have the major stakeholders in behavioral health and primary care at the table, including our FQHC, which is Community Health Centers of the Central Coast. We have county, both the Behavioral Health Department and the Public Health Department. We have our Cal provider. We're a single county-operated health system, Cent Health, and we've had participation from the two local hospital chains with Tenet and Dignity. We've also been able to bring in Cal Poly, which is the major university, but also has a lot of the crossover population between mental health and physical health. So our goal is really are to adopt a blueprint for system-wide integration. I think we've taken a lot of steps locally, certainly within the clinic, within the FQHC, integrate primary care and behavioral health. But what we're trying to do here is look system-wide, particularly in the era of sort of new reimbursements or expanded reimbursements and eligibility in Medi-Cal for a full scope of services. So there's an opportunity for everyone to sit around a table and specifically discuss the behavioral primary health integration. Interestingly, and among sort of problems in organizing everyone is we really only have one of everything. We have one FQHC, we have one Medi-Cal plan, but trying to get everyone at a time in the same place has been one of the early challenges. But I think we're set at this point. And what we're delving into now is really working on sort of getting some basic data, developing a gap analysis on what services are currently provided, what the potential demand is, and of identifying who the highest risk or the most needy patients are so we can start redirecting a lot of the resources in an integrated fashion. Let's see. You're moving the slides and I'm not.
Do you want to say about your, okay, so we're on challenges. Go ahead.
Yeah, no, I actually have the slides up on my laptop.
Okay.
So, you know, the challenge has been this is really the first time that everyone sat around focused on this particular issue. And even identifying all the other projects going on in the county, which few of the, you know, there's a large number involved, but not everyone knows about everything. So at this point is a lot of information sharing and sort of collective visioning. In terms of resources that we need is really to identify those sort of similarly situated counties. We're not a provider county here, so there's no county clinics, at least on the physical health side. Certainly our services on the behavioral health side. So that makes it somewhat interesting. And we're relatively not rural, but a small to medium-sized county. Sort of understanding how other counties similarly situated are working on these issues would really be helpful. It's something we can share. I don't know that it's a real biggie, but we take the 6 levels of collaboration, which is in a beautiful PDF, and we convert it into an Excel format. So what we're going to do at our next meeting is actually be able to highlight sort of box by box or cell by cell, not only where we are, but where we would like to be. So it's just we thought it would be an easier planning tool. So any questions?
That's great. Well, I'm sure people will want to see that tool, so maybe we can make sure others get a copy of that once it's ready to be shared. All right. See, the folks from Redwood, are you prepared? Are you ready?
Yes, thank you. So my name is Michelle Rosacci, and I'm the Population Health Coordinator at Redwood Community Coalition. And for our project, we're convening 2 behavioral health integration task forces in Yolo County and Sonoma County. Very different counties, so we're learning a lot. But the key objective that we wanted to share was that we're going to be holding about 7 to 8 task force planning meetings to develop vision, collective accountability structure, protocols to strengthen the current systems, and establish information pathways to connect county EHR systems to our CHC Community Health Center EHR systems. One of our biggest goals. And so far we've held a couple of meetings, I think 2. So it's been interesting. We're just trying to start to learn more about each other's entities and how we relate and work with each other. So I would say early success with collective accountability has been that each task force member has been responsible to bring data to the group meetings for discussion, and that engages each task force member to contribute to the development of our collective accountability structure. So we have had some emerging challenges, and one of those is that we have a lack of community-based organization involvement in the group. We know that community-based organizations are, large players in behavioral health within these two counties, and so we're trying to figure out ways to bring in some of those community-based organizations that are such a big part. Also struggled with the workforce and the cultural competency within providers for behavioral health. So, constantly looking for bilingual, bicultural members for behavioral health services. So resources that we need and that we could share. Well, we could share the early integration of behavioral health providers into our team-based settings. Many of the community health centers that are part of the network offer some behavioral health services on site. And one thing I should mention, in our task force groups, we have community health centers, representatives from community health centers that are part of Redwood Community Health Coalition, as well as county agencies. So in Sonoma County, it's the Behavioral Health Division. We have a couple of representatives that have been participating. And then in Yolo County, we have the director of their division for our task force. So the thing that we would need assistance and expertise with is to develop a navigation map of how the current systems work together. And those would obviously need to be different in two different counties, but we're definitely struggling on how we can kind of develop that and make something, maybe a graphic designer. I'm not sure who usually designs those types of maps, but that would be really helpful, because what we're finding is it's not easy to navigate the system, and it is changing. So I think that would be a good item to develop as part of our task force. We could also take any questions.
So we're continuing to gather some of the questions in the chat, and there are several that are coming up. So it looks like we will definitely have time afterwards to ask questions. So thank you for that. Excuse me, Michelle. Let's move on to the other part of the state, San Diego, and Marty or Nicole, whoever from your shop would like to present San Diego.
It'll Marty. And the first thing I wanted to mention is that if I had known others people's slides would have been so beautiful at a graphic design, something ours. But our key objective in 3.5 words or less is to improve cross-system collaboration. And by meaning collaboration between our primary care, specialty mental health, and substance abuse treatment providers. Our grant has 6 kind of unrelated pieces to the project. So I want to focus on 2 that are more directly related to our objective. So I'm going to be focusing on 2 pilots that we're doing. The first is focused on collaborative treatment planning between specialty mental health and a primary care organization. For that pilot, we've identified our partnering specialty mental health and primary care sites, and we've been to determine the next steps. And we are currently identifying the shared patients and developing the required documents, including the procedures and protocols that we're using. We expect to actually begin the collaborative treatment process by mid-December. We see this process allowing the 2 agencies to ensure that they're working in the same direction by sharing and comparing treatment plans, and it be aligning their treatment goals and making sure the patient is being provided the proper medications by sharing patient lists. So in essence, we hope that we'll be able to, by doing this, kind of create one meta treatment plan. And through this collaborative treatment planning pilot, we see the potential for reducing duplication and cost and increasing quality of care. For example, when we were meeting, we started talking about the challenges that the specialty mental health programs have to get clients to go to the lab for a blood draw. And the primary care partner said, that's something we can do quite easily for you. And similarly, we started having discussions about then for the specialty mental health side to have their clients have an EKG if they're taking antipsychotics, which is also hard for them to get. But the primary care folks said, that's something we can do in-house for you and then share the results. So these are examples of ways we think we can reduce duplication, increase quality of care, and reduce costs. Our second pilot involves actually transitioning people with serious mental illness to primary care. In this pilot, we've identified our partners with 1 special mental health program who we've paired with 3 different community health centers. We've met several times to discuss how the process will work. We've identified key staff at each agencies who are going to do the work on the ground. and the special mental health provider.
Transition.
Oh, no. So we don't have fancy slides, but music is a good touch.
Any way to identify who that is?
Not us.
I'm so sorry. I can tell that's our hold music. Sorry, that's our hold music from LA Care. I'm going to call everybody else who's not in the room, and I'm so sorry. That's Alison. That's our fault.
Thank you. Can you shout?
I don't see it working.
Yeah, I don't think that's gonna work.
Oh no.
We can hang up and dial back in.
I hate to do a Jack break in the middle of
Be able to mute you by the organizers call
Yeah, exactly. They should be muting everybody.
right upon us.
You tell me who it is, I can try and mute on this end.
I know.
This is Alison. I can tell you who the names are. I'm sorry, I'm going to call them out. It's either Maria Cayeros, Wendy Schiffer, or Hugh Nguyen.
It's you. You can see it on this.
Oh, I'm so sorry. I'll call him as well. I don't know. He's a little new to our phone system, so you may know that it does this.
Hey, all right.
Oh. I hope you all enjoyed that little music break. But we're going back to Marty.
I had to mute. I muted you.
I was on
Sorry
such a
about
roll, too.
It's not nearly as interesting as a serious mentally ill population being transitioned to primary care. So see that back up.
But that is where we left off. So we're talking about the second pilot where we will be transitioning individuals with serious mental illness to primary care. Where we right now is a specialty mental health provider has identified a significant number of clients who are graduate from specialty mental health and are patients at one of the 3 community health centers who are going to be involved in that pilot. So we're in the process of finalizing the protocols and the processes we're going to be used for determining who's ready to graduate and the documents we have to get in place, and we expect this pilot will begin December 1st. Intervention in this pilot is actually staff from the community health centers, so behavioral health consultant type staff who are going to the specialty mental health site to provide 1 to 2 transition visits for people who are ready for graduation, and we believe these visits will actually improve the number and the success for transitioning individuals, because they'll get an opportunity to know somebody from the community health center. The community health center staff will get a chance to the individual for what it's going to be like, treatment is going to be like at a community health center site, and the community health center staff will also get a chance to kind of liaise on the person and see if they really feel like the person's appropriate for their site as well. As far as developing collective accountability, we're really fortunate that the participants in our particular pilots were members of our learning communities and our regional triads previously, so people know one another and have made commitments to one another through the process of the learning communities and the regional triads, so we actually feel like that's one of our strengths. As far as early emerging challenges, one of the pieces of the project was involving developing internship sites at the community health centers for people from graduate schools, and I was really surprised when I went to visit the graduate school that I went to, their kind of lack of gratitude and almost arrogance about expecting me to do the footwork and paperwork to set up this internship site. So I say sort of tongue-in-cheek, I want to figure out strategies for that. What I probably need is just to cool my jets. As far as resources we can share, we do have a pretty long history, like 7-year history of doing integrated, related, and focused activities through county and MHSA funding. We've been doing impact for about 7 years. We were involved in the San Francisco PBHCI project. And we also have a website called at sandiegointegration.org, where we have a variety of materials, including stuff from our annual integration summit, which we'll be doing in December. It'll now be our 5th year. information from our learning communities and the regional triads, which, as stated, have kind of become the basis for these pilots that we're doing now. And over the webinars that we've produced in the last few years about treating a variety of behavioral health issues in primary care. And those recordings are available at that website as well. So we are really excited about the opportunity to get to know other people doing this great work. We found, based on our previous experience, that getting to know others doing the work really ends up being helpful when you are talking about what you're doing and what other people are doing and learn from one another. So that's us.
So to add to what Marty said, I don't know if this is Nicole, I'm not sure if you're planning on doing this. I've been trying to take notes during all of the presentations, but if we could get some kind of, I don't know, one-pager with maybe just the goal, the key people involved, and a contact person, that would be really helpful, just really limited 1 or 2 pages so that we can contact individuals in between any of the meetings that are organized.
This is Mary Nicole. Yeah, that's a great suggestion. We will definitely do that. We did send out with these PowerPoint slides to you all a one-pager of the overall initiative with a list of each of the partnerships with the lead contact person. But I understand what you're asking for, which is a little bit of a paragraph on each of the projects, which I think we can also pull together. And I'll just take this moment to encourage those of you who are listed at as the leads on that the 2-pager that we sent out with these PowerPoints. If you have changes or additions, I know that some of the partnerships are still very much in flux and fluid. Please let Erica always know that we are trying really hard to keep a master list of everybody and all the partnership organizations, but we can only do that as well as we have the information to do it. So if you send that to Erica, we'll take responsibility for keeping those lists updated, and happy to share those, in detail with each of you if you need them. And for sure, we can do the paragraphs with the lead contacts for everybody.
Thank you.
That's a good suggestion, Nicole. Thank you, Marty, for doing that in that challenged moment. And make sure you have your phones on mute. I did hear a little talking in between, but I think we've got that resolved now. So let's move on to Merced, and I believe Karen Lincolns, are you leading this? We got a note from Kathleen that you'll be doing this one.
Yes, I am.
All righty, take it away, Karen.
All right, hi everybody. My name's Karen Lincolns, and I'm with the Integrated Behavioral Health Project, and today I'm speaking on behalf of the Whole Health Partnership of Merced County, and I just the title, the Whole Partnership of Merced County, is actually evidence of an early success for this group, because they, prior to the last meeting, were known as the Merced County Healthcare Consortium. It's the evolution of this group, and the composition of the group includes the County Department of Public Health, which is the agency for this group, Valley Health Centers, Livingston Community Health, which is also an FQHC, Big Health Mercy Medical Center, the Central California Alliance for Health, which is the health plan, Merced County Mental Health Department, and then recently they have added NAMI to the mix here. And the key objective for the work of the Whole Partnership of Merced is really to develop an action plan at the end of this year that is a result of a planning process to identify opportunities for collective action that are going to strengthen the safety net system in Merced, and really start working on integrating behavioral health services within county, with very much with a focus on prevention as well as treatment. And the group has really also conceptualized this as integration, as expanding beyond the traditional boundaries of health and behavioral health, but also to include social services, education, public education systems, and the criminal justice system and law enforcement. And in terms of their early successes with accountability, the first piece was bringing the partnership together. They had been meeting as a group for about a year, but now they are really coalescing around, the work for this grant. And as that, they have been focusing very much on establishing an overarching vision which what they've come up with so far is that whole health and wellness for all is a priority in Merced County, and the mission becomes the Whole Health Partnership works to transform Merced County community services and supports for centered mind, body, and soul wellness. And that's very much a reflection of a central tenet of cultural competence as reflected for that county. And in terms of some of the additional early successes that they've had, they have been, you know, as I mentioned, they've been meeting as a collaborative for a couple of months now. They created the shared vision, but another important component of this is that they are engaging the clinics as well as some of the public health programs to look at opportunities to leverage existing outreach and engagement strategies to the community to also bring in the community voice into the planning process. And that's a little bit undeveloped at this point, but this is very much an intention, and I think that it gets to some of the stretch goals for data collection in terms of having community input and voice in the planning process. They've also identified data and shared data for the gap analysis, and they've also worked on what they want the gap analysis to encompass and really, you know, kind of focus on. And in terms of early challenges, I think that the biggest thing that they are facing is that almost every organization that I listed off as members has had some sort of leadership change, and in the last couple of months. So they're in a process where they are looking to re-engage leadership. They certainly have senior management that has been consistent, but they too be working on continuing to engage leadership. In terms of the resources that they can share, this partnership, I think, one of the very unique features of compared to what we've been hearing with the other grantees is that this is led by public health, and so it very much brings a public health lens to the work. And the way they see public health in Merced is that it really is a neutral convener for bringing together the primary care side and the behavioral health side, as well as bringing in these other entities that I mentioned. With this public health perspective, it also gives them an opportunity to begin looking at this from the standpoint of a client. It's client-centered, but it very much is bringing the focus on prevention and treatment. And another component that they can be, another resource that they can share that they are focusing on includes the innovation of the Stanford Chronic Disease Self-Management Model, which they are now adapting to use for people with serious mental illness. And this is it's been done in the past, but they're doing it in a slightly different way. And so I think that will be a big resource to be sharing across all the collaboratives. And in terms of resources needed, at this point, I think the primary resources would include any successful strategies or models for integrating these other systems into the behavioral health and primary care integration. So that would include the school systems and also law enforcement and criminal justice. They do have some resources and experience with school-based health integration, but really looking for something that is more at the systems level as opposed to clinical models. So that would be those are resources needed. And with that, I'll stop.
Okay, Karen, thank you so much. That sounds really comprehensive. Maybe we'll get a little bit more about that Stanford Chronic Disease module that you're talking about. So I'll follow you on that. How about Los Angeles County? Allison, I assume that you or Michael will take the lead on that?
Sure. This is Allison speaking. So in Los Angeles County, we've kind of working on our name. It's still kind of flux, but we're thinking we're calling it something like the Health Neighborhoods Planning Collaborative, Joint Planning Collaborative. And so LA Care Health Plan is the lead agency with support from the Integrated Behavioral Health Project. But we've got a lot of folks at the table. So we have the departments of mental health and public health. Public health is kind of playing two roles, two hats. One is that in LA County there are substance use disorder treatment providers, and the other role is also in their more traditional planning public health prevention role. We also have the Department of Health Services and our Community Clinic Association, and then the Insured the Uninsured Project. So we're really excited to have a lot of those folks at the table, and that relates to our main objective, which is to really conduct some joint planning. The healthcare landscape has changed a lot with Medi-Cal expansion. We're really excited to be able to bring a lot more folks into the health system, but that's got some challenges for us. The specific way that we're approaching this is both as agency and then later on in our project at the community levels, we're going to be looking to develop health neighborhoods that really facilitate and promote coordination between the physical health providers, mental health providers, substance use disorder service providers, and community and social service providers, all those different folks serving shared clients and patients. So, in terms of some of our early success, collective accountability, creation of a steering committee and a charter that'll describe our goals, objectives, and some of the milestones so that everybody has one concrete document that they can sign on to and agree to. And something we imagine that will, get it in pretty good shape to start and then continue to update and change as we learn more over the course of our project. So in terms of earlier emerging challenges, this should come as a surprise to no one. But we just realized that Los Angeles is really big and really diverse in terms of the populations, the languages, the ethnicities, the different sort of neighbor compositions, suburban, rural, urban, all mixed together, and also diverse providers. On the physical health side, we've got both county-operated facilities and also community clinics. And then we also have a number of private providers serving our Medi-Cal patients, which is great, but a really different structure to work with. Lots of different models on the mental health side and substance use disorder side as well, and then a lot of different community agencies to work with. So with this being just, kind of a one-year start to a longer process, we were thinking about how we're going to thoughtfully choose areas to focus on, either geographic or maybe population-based, likely a little bit of both. So are we going to hone in when ideally, the idea of having a health neighborhood where providers serving shared clients are communicating with each other, that sounds like a pretty good thing for everyone, but you kind of got to start somewhere first. So if we could go on to the next slide. So in terms of some of the resources that we need, I think we're looking to get some models from other places. How are the various kinds of health providers on the physical and behavioral health sides and community social service providers coordinating, communicating? So we know some of the existing models come out of Atlanta, which has a more physical plant base, and then there's some in Portland as well. But if folks know of others that we should investigate, would really appreciate that. So, what are those key ingredients to their success, and some of the, specifics like how do they share data, what's their infrastructure like? And some of the resources we can share. We do have some ideas on effective data sharing and communication at the agency level. I think we're really fortunate to have a health plan that's a good relationship with our county departments of mental health and public health, and really we're in the process of building our system-level data sharing. We all have experience from our Department of Mental Health with a lot of past integration and co-location projects. For example, the partnering of health and mental health providers serving shared clients during the low-income health program. And then also especially from our mental health side, lessons learned from implementing different behavioral health integration models, so different kinds of treatment models as well. Looking forward to being a part of this collaborative and learning from everyone who's participating.
Very cute, Allison. Yes, LA is very large. You clear? Hit that nail on the head. All right, let's go on then to the San Bernardino Partnership and let them tell us a little bit about their project.
Hi, my name is Liz, and I am the project manager for the Integrated Safety Net Partnership, or ISNP for short, and it's a project under the Community Clinic Association of San Bernardino County. So we're also a very large county, and Just a little bit of background on ISNP. We are a collaborative that was formed last year by a diverse and large group of safety net providers. And our vision for this collaborative is to achieve a public safety net system that is integrated, cost-effective, patient-centered. So this year's focus being on primary care and behavioral health integration, we tried to leverage some of the preliminary work that we did last year and assessing, where our safety net providers were at as far as the readiness to integrate existing integration efforts that were identified. So this year we really hope to develop a collective vision for advancing integrated care in the county and creating a San Bernardino County Integration Action Plan. Some of the successes in collective accountability have been partly as a result of our ISNP partnership. During our last in-person steering meeting, we realized that we needed to kind of take a step back and really follow up with our partners individually to discuss, what their vision was for integrated care, respective to their individual organizations, and then, kind of how they foresee that for our group and the goals they perceived. So we'll be gathering together, with this feedback together as a group in person this month, and this meeting will be facilitated by IBHE with Karen Linkins and Jennifer Bryan, and we're going to focusing us in a visioning process across our different stakeholder sectors and really identify and define some goals for integration using the 4-quadrant model. And we'll be discussing, our partnership and really diagnosing some of the issues as they relate to the 3 tiers and using that to help us develop a collective vision, an action plan for integrated care. Some of our emerging challenges, just as I mentioned, we are also a very large county and we're a very diverse group of partners. So defining integration as a region and at a system level has been somewhat of a challenge. And speaking with our partners individually, everyone has really great ideas and concepts as far as what integration is, and some folks do have current integration efforts. So we really want to leverage some of their work and not duplicate what's already being done, but really seeing how all of this ties together for our county. The challenge I wanted to briefly touch on, is our objective of using technology as a way to facilitate integration. The first one being health information exchange, which we began implementation for last year, and that's steadily and positively unfolding for our county. But we realize, especially for primary care and behavioral health integration, there are certain pieces that haven't been fully addressed, especially regulatory issues as far as sharing very sensitive but very important data across the sectors in our partnership. Also, the technology piece that we're hoping to address as part of this grant is using telehealth as a way to aid our integration efforts, using telepsychiatry for this project, and we're having our first work meeting this Thursday. But to be honest, it has been a challenge to gather together as a group. Everyone has different ideas as far as what they want to use telehealth for and different needs. So, we're having our first work group meeting this week, and we'll be kind of talking about how telehealth could be used for integration and, ways that we can meet our psychiatry needs, and also pretty soon in the county how we could use telehealth as a way to address some of those issues. And then moving on to resources needed. So, like I said, our partnership touches as far as, how we share patient data information. So for partnerships that are addressing these barriers, that would be great information to hear about. For those groups that are a little further along the road, it'd be great to hear, what systems and practices are working for them. Also, as a project, as an ISNP project, we're constantly seeking additional resources to support our efforts. So if there's any additional financial resources that the group could share as far as, how we could sustain our efforts and continue the work that we start this year would be, very, very helpful. As far as resources that we could share, like I said, we're a pretty diverse group, and we're kind of taking this on a little bit ambitiously as far as taking it on as a regional approach. So, we're very happy to share our experiences in this approach, and then also using an existing collaborative as our platform, and how that will help leverage this project and be able to continue the work that we began. And then, and also speaking with our partners, I know there's a very strong interest among our partners to measure integration as far as how it impacts patient navigation and patient experience across systems of care. So any information that we gather or any ideas, we would be happy to share with the group. And thank you very much.
That's excellent. Lots going there. I think we have one more. Oh, two. Okay, so let's go to Siskayu. And Kathy, are you on the call? Are you going to lead that?
I am on the phone, and I'm happy to share with you some of the work that's been happening here in Siskiyou, Siskiyou County. Our organization is the Behavioral Health Task Group of the Siskiyou Healthcare Collaborative. The Healthcare Collaborative started working about 2 years ago to identify ways to work much more effectively within our county. As I said in the slide, as you can see, Siskiyou County is located on the Oregon border, so we are one of the 3 northernmost counties in California. We're very rural, very expansive, mountainous, and our population is spread over a huge area, 63,000 square miles. So what we have are about 12 different pockets of population, the largest of which is around 7,000 to 8,000 people. Most are 2,000 or less. So lots of pockets of population, and that becomes part of our challenge, is getting services out to areas that are very remote, and transportation becomes an issue. Our lead agency is the Siskiyou County Community Services Council. The Community Services Council's mission is to coordinate social, educational, economic, and health resources to strengthen families and build more cohesive communities. So it's an excellent fit with this project. Our key objective for this portion of our activity is a comprehensive assessment of the services that are available and exist within the county, and identification of the gaps leading to knowing what opportunities are there for enhanced integration of services. Some of the early successes that we have, and I need to say that part of our early success was really, and the Behavioral Health Task Group is relatively new, part of our early success was just bringing everyone together and having an open dialogue about who was doing what and for whom within the county. And so many of our providers were operating somewhat separately, I won't say consciously independently, but operating separately and delivering services. And so we have already identified areas of duplication and potential areas of additional services if resources could be shifted. So one of the aha moments that we've had is that identifying the payment source for these services is critical in determining the who, what, and how of our current delivery system. That's something that we are working to address right now in our assessment. One of our biggest challenges, we believe, is determining what the actual demand for services is within a population that has not previously had access to those services. So that's complicated by the addition of AOD services, which we think needs to be included, and also the need for multiple assessment tools because of the diversity of our providers within the county. So that assessment has become much more challenging and a larger aspect than we originally thought it would be. Some resources that we would look to have as a part of this process would be assistance in determining the volume of that population that I just talked about, and that population that now has access to behavioral health services. We're also looking for models of integration that do work in other rural counties, and we're very open to some regional efforts. That's part of the mindset here in our community, is that regional efforts do often work for us. There are just not enough resources to go around otherwise. So thank you.
Okay, yeah, your geographic span is just so humongous. It's just overwhelming every time I hear you speak of that. Okay, let's finish up then with the California Consortium for Urban Indian Health, and I believe, Esther, you're going to take the lead for us on that.
First, let me just say what exciting projects everybody's working on. It's really an honor to be part of this cohort. I will say, first of all, that the California Consortium for Urban Indian Health is the statewide membership organization. We are made up of 10 Title V clinics across the state of California. So it looks like we might be the only statewide project. When we think about behavioral health integration, we saw that as a real opportunity to assess where kind of our cultural and traditional health actually fits into that. So we also with ACA mentioning complementary and alternative medicine as a component of integration, we saw it as a real opportunity. So we are interested in developing a policy change strategy to incorporate and to sustain American Indian traditional and cultural practices into this integration process. Next slide, please. Our most important objective, I think, is to develop strategies to influence policy reform and support sustainability planning for American Indian traditional cultural practices. When we think about that, we think about integrated care, and for us as American Indian people, we think, oh, wow, we actually offer holistic forms of medicine. So for us, this is about returning to our traditional ways of knowing and traditional ways of existing. So we've been successful at putting together a traditional health task force. And it's made up of behavioral health providers, medical providers, traditional healers. We have tribal representation and actual leadership from tribal councils. We also have community leadership, people who are actually instrumental in creating lasting legislative change at the state level. And then we also have, we can leverage our membership leadership, and we have a wealth of knowledge there. So we've put together 2 chapters of the Traditional Health Task Force. So we have a Northern California chapter and a Southern California chapter. And I think when it comes to early successes around collective accountability, because we're a membership organization and this type of integration with respect to cultural traditions is one component of our strategic plan. So it didn't take much to get buy-in from our membership organization. And also the fact that this is a movement towards Indian self-determination. And in the 1975 Indian Self-Determination and Education Assistance Act, it was the very first time the government system said, Indian people know what's best for Indian people when it comes to their health and education systems. So when it came to pulling together a traditional health task force, we all had a collective vision around this because we've been working towards this since 1975. Simply, though, an emerging challenge for us was the fact that there has been a lot of effort towards this since in the past 30 years. What we're finding is we initially wanted to hone in on other change strategies that have been successful. Like, there have been other state models and even like Canadian models that we were really focused on. But what we found was that within these pockets of communities of Indianities, we found other models for policy change. And like we found models, for example, in the tribal traditional health policies. We found models in the VA. We found models within ICWA. And so now we have a ton of data and history that we kind of have to sort through and assess and to determine the successes and barriers of these change strategies. So it's exciting, but it's also, just a ton of extra work. In terms of resources, we really are focused on sustainability, and we need to look at innovation or innovative sustainability strategies when it comes to, perhaps billing for traditional and cultural practices. And so I would love to hear some of that from this cohort. And I would put something down as what we could share. Let's just strike that for a moment. I think something that SACUI can offer is that we actually have access to tribal consultation. So with the implementation of ACA, there was an executive order that required states to work with tribal communities, and urban Indians are also included in that. So that gives us a really unique political position and a voice within changes when it comes to kind of integration and just overall health care. So I hope that, as we begin to build relationships in this cohort, that you'll remember that we have access to that, and, we can come together around things that impact our communities to create change.
Hey, Esther, on that point, I had a question since I think we have time now to take some questions. I want to, first of all, thank you all for really, really thoughtful presentations and information that you shared today. And I'll just echo Esther's comments that, it's really wonderful and really a privilege to be part of such an interesting cohort of grants that are going on throughout the state. And I think it's really exciting to think about the progress and the potential for true change that you all are poised to make in the care for so many patients. I wanted to ask Esther if you could just comment if somebody wanted to follow up with you on how to access you as a resource for this last piece that you were just talking about. What's the best way for them to do that, for their communities if they want to get the Indian health perspective?
Sure. Well, my email is Esther, E-S-T-H-E-R, @ccuih.org. That's usually the best way. You can also get that from our website at ccuih.org.
Okay, great, because I'm sure you have a wealth of resources there that the rest of the partnerships might want to use. So why don't we turn to you, Erica, or Rachel, maybe I'll stop for a second and see if you want to make any overarching comments as the program officer responsible for this cohort. And if not, I know there's been some questions being chatted to Erica, and we'll go on.
One, just to say the work is so impressive, and the array of partners and the array of challenges and opportunities that folks are addressing is just really exciting, and I think gets to the heart of why we wanted to bring people together. So I appreciate everyone's patience in moving through all the presentations, and go to questions.
Okay. So, Erica, I just follow these ones in the chat. You've been recording them as they come in, correct?
Yep. They'll be all there in order. The first one is from Alison for Shark.
Okay, so we'll try to get through these, and if we can't get through them all, as I mentioned, we're going to copy them and get them back out to you via email. So the first question is for Shark, and it's a question asking, how is the Shark Collaborative organized and funded?
This is Lynn. So the HANC, the Health Alliance of Northern California, which is a consortium of safety net clinics in the North State, provides the leadership to HANC. Even the members of HANC, we are there are three hospitals, two big hospitals in Redmond, one rural critical access hospital in the rural part of the county, and the health department. We all put up a modest amount of money, sliding scale depending on how big you are. And Doreen, the executive director of HANC, manages to, pull money out of other fundings that we have as well. So that's the way we're funded. And what was the other part of the question?
How organized?
How organized? There's a woman, a consultant, Linda Shaban, who works just in a consulting role with Doreen. Linda facilitates the meetings, manages the in-between communications. It's a fairly decentralized approach. I would say that we have objectives. The integration of behavioral health and substance abuse is one of three. Each of those topical areas has a committee, and the committee members of those three topical areas are actually putting in quite a bit of time and energy to move things forward.
Oh.
I hope that answers your question.
Yeah, great. Thank you.
There's a question here for the Almeida Partnership for Jennifer. If you're still on, can you share more about the process, your process for ensuring that you're addressing the root causes? Oh, yeah, I wrote that down too. You mentioned that you found that you had to kind of check your assumptions, and then you're taking that out to the stakeholder groups. Can you speak a little bit more about that?
Sure. So we have a couple of existing tables that we were able to bring this project to get some additional feedback on kind of relevant components of our project. One is a collaborative clinical leadership team. We call it our Clinical Implementation Work Group that brings together clinical personnel from our behavioral health care services, primary care, or community clinics in the county to particularly check in on some of the assumptions that we had around the Medicaid agreement that we had as a part of our project to really understand what was the root issues between patients that were jumping from one part of our network to the other, particularly around discharging from our psychiatric hospital. The Almeida Health Consortium also convenes a group of leads from all the community health clinics for their integrated behavioral health project. So also able to bring the project to them to get their read on kind of the issue on communication, where are the gaps in information that they need, that they expect on a day-to-day basis that would, if filled, really enable them to better meet the needs of their patients when they come into their clinic.
Mm-hmm. Some of the focus is it broader though than just the psychiatric medication at this point?
It sure is. Those are the kind of especially interesting conversations that have come to pass so far. Though within the midst of our steering committee, we've also been able to bring together the IT specialties from the Alameda Health Consortium to get an idea on how our very low-tech version of sharing data, that might even just be in the world of sharing spreadsheets, which patients need additional coordination and follow-up to find out what their vision would be to get this data even more integrated into their electronic health record to really leverage all of the technological tools that we have available.
Mm-hmm.
Yeah.
Thank you, Jennifer. And on that, actually, I'm reading in the chat box here, there are a couple questions, several actually, around some of you mentioning data sharing, and I know I had specifically one about your project, Joel. And can you speak a little bit more about what types of data you're bringing to your task force membership there? And I think a couple other groups you mentioned, partnerships those on the phone, you've been talking about cutting your partnerships and the collaborations to bring data to the table. But I know, Joel, in particular, you mentioned that in yours. Can you share a little bit more about what data points you're actually bringing to the task force? What are people bringing?
Yeah, so we're at the early point now. What I'm trying to find out from health plan, from our mental health plan, is what's been utilization to date, the new expanded benefits, what are the age ranges, what's the severity, and then also how many has the plan sort of cross-referred or tried to refer to the county and vice versa. Because there's a little bit of a war on that. Also trying to get current utilization data from the clinic to find out, from our FQHC to find out exactly what they're seeing at this point. And I've also been in contact with the local hospitals to see what has been going through the ER and admissions in terms of both primary and secondary behavioral health diagnoses. So that should give us some sense of what's going on now, and we're also on a different level to find out what some prevalence data are and what we might be expecting sort of in the general population.
How about you others? I know LA Care, you mentioned some, and I'm curious also how the if you're any pushback from your legal counsels, or if that's been resolved, and because you mentioned there's been quite a bit of data sharing and going already in LA.
Sure, this is Alison speaking from LA Care. So I think some of the data sharing has been specifically for the MediConnect project that we have here in Los Angeles. And there's actually some, explicit financial agreements and really clear MOUs about what LA Care as a health plan is responsible for versus DMH as a specialty mental health provider versus DPH, substance abuse prevention and control for the SUD piece. So that's something where we kind of have two tracks. One track is the system, more planning kind of track, figuring out, you know, how many high utilized services each system has, are they the same people, you know, more a sort of needs assessment level. And then we use the interdisciplinary care team model for actual individual clients where, you know, something that I know we have kind of where we want to go and we're not quite there yet. It's going to take a long while simply because, you know, there's just a lot of levels. You have potentially the case manager, care manager at the health plan. You've got if someone's a specialty mental health client, you may have a navigator or care manager on that side as well. And then figuring out actually the physical health provider versus the physical health plan, there may be even a third. People can be really interacting with just a lot of different individuals. So trying to figure that out, you know, it's in some ways we get better at doing it and more experience doing it when someone's in a crisis, because then there's really an incentive to figure out what's going on with this person, who the provider's touching them, how can we fix it. Trying to make that more routine is definitely a challenge that we're continuing to work on.
Anybody have any thoughts on their data sharing challenge or tasks? Because that comes up a lot in a couple of the questions.
Yeah, Michelle Versace from Redwood Community Health Coalition, and I'll just chime in and kind of talk a little bit about the data sharing that we've already engaged in. And so Beacon Health Strategies were able to bring some utilization data for the current year, which was very helpful. It was partnership-wide, so it wasn't local, but it was still helpful. And then our health centers, our FQHCs, they brought the number of patients served in 2013. We haven't yet looked at 2014, but we started looking at 2015 and types of services that were provided. If they provide substance use services, services for children. We also wanted to know the number of behavioral health staff and in what professional categories and how many FTEs. I wanted to know the breakdown of patients on Medi-Cal and uninsured. In the county level, we're looking at the population has changed, what services are available, and then we also wanted the breakdown of Medi-Cal and uninsured. That's a summary of what we've discussed today.
With the
plan with our community health centers and with the county agencies.
There's also another question, which was in terms of you mentioned that one of the resources you needed assistance with was creating the navigation map. Who's the audience for that? Is that something that you're going to use as a team planning, or is that going to be for the consumers, the patients? How are you using that?
We actually, this is something that just came up after our last meeting, so we haven't had a chance to discuss it as a group. We just think it would be great to share that with consumers and our community as well to start out ourselves first.
So you're breaking up at least on my end on that. I don't know.
Oh, sorry. Yeah, we'll just wrap it out for ourselves to start.
Okay. Okay, very good. I'm going to see if we can get a few more of these answered. There's a couple questions here for you, Marty, from San Diego. One is, how is it you mentioned that you're identifying, I believe, the seriously mentally ill who are graduating. So to get into, I think, to be managed in the primary care setting, what are the metrics or the measures you're using for that?
So we have some history doing this with a previous project called iCare, and the protocol or the criteria are things like people on psychiatric medication for more than 6 months, no hospitalizations in the last year, no active substance abuse. What else am I missing, Kelsey? What do you think?
The MORS score.
Oh, right. So the milestones of recovery scale, what's a 6 or better on the MORS scale, things like that.
Fairly well developed set of measures.
Yeah, we're going to start with that with that list, or we have started with that list, and we're just going to allow partners to refine it to to their liking, and we'll use that.
And there was another question. This one's for me as well, but I wondered. I know that Alison just mentioned in Los Angeles that they're also involved with some of the data sharing work that's going on around the Duals Demo project. And I wondered if there was any overlap at all in San Diego, and then also Almeida, maybe you could comment on that, with the work you're doing, since both of you are working with the serious mentally ill population that's often part of both Medi-Cal and Medicaid. Any overlap at all or intersect going on yet in your community on that with project?
I'm looking at Nicole.
I think there could, potentially there could be some overlap with patients, but we haven't been meeting with the stakeholders or any individuals that are involved with the MediConnect.
Not yet, okay.
Anything to add on that?
No.
Okay, how about in Almeida?
Yeah.
I know you're another demo county.
Yeah, well, we the same thing to try to pull together. We definitely, like I mentioned in our slides, we really want to involve the Medi-Cal piece because we just know in terms of volume of patients that can benefit from this kind of work, it would be silly to involve them in the conversation. But we're kind of in our beginning research phase to figure out even what kinds of data sharing could be happening and who would we talk to and what could we build off of. So it's definitely something we're aware of, but we still have some work to do on that.
Okay.
And I guess to add a little more, Mary, this is Nicole with the whole Cal MediConnect. We really built our program based on our relationship with the tribes. So it wasn't necessarily bringing in a lot of other stakeholders. It was taking already participating agencies that were members of regional triads.
Right.
Really just moving to the next logical step, I think.
Right. Both the members for Center for Healthcare Strategies are on the call have deep knowledge about the Duals project, so we hope to be able to shed light on some of that in due time with all of you, and we'll be thinking more about that. A couple more questions here. Since we have time, I'll try to get through. Let's see. For for Karen, the Stanford, can you mention again the tool, the Stanford Chronic Disease Health Model, how that's being used?
Sure, yeah. The Department of Public Health actually has had some past experience using this tool. They had a CDC grant, I think it was a CDC grant, it might have been a state grant last year, where they're using it, and they have trained, this is a train-the-trainer tool, and it has, a lot of evidence supporting it, and it has been very effective for many of the chronic diseases, including diabetes and COPD and other diseases like that. And what we're doing is an adaptation, under this grant, and also with some new CDC dollars, they're going to be an adaptation where they're going to be targeting the seriously mentally ill population. And there has been some experience doing this in San Joaquin County. Mm-hmm. This is a little bit new, and it's pretty exciting. And the other piece of it is that they are doing it not only in English, but they're also doing this in Spanish. And they have they trained up people, and now they're doing application for the SMI population.
Hey, this is Jennifer. The Stanford model, the chronic disease self-management, has been growing, and they have a depression management model for that has been effective with not necessarily with the seriously mentally ill population, but they have a depression module. And I think that what is exciting about this, bringing this into Merced with the public health lens, is they really are trying to think about ways to bring disease management principles to individuals with serious mental illness, while also bringing, depression management skills to other folks. So they really are looking at this in a bidirectional way. And obviously, it's a self-management model. So you have individuals who have already gone through the training program, training others in a multi-week class format.
So if people want more information on that, maybe we can get a link from you, or if just put a resource out for that.
Sure. Yeah, absolutely.
That would be great. So 3 minutes left. I want to stop. I think we have a couple questions we didn't get to, which we will definitely answer. One is around steering committees, how people have been building their steering committees, so we may send that around. And then it looks like some people want a little bit more information on the 4-quadrant model, so we can help pull that together. Any closing thoughts from you, Rachel, or Elizabeth?
We appreciate everybody's work and our presentations. It was great to hear, and I really appreciate everyone's questions too. I was getting a lot out of the questions and the answers in this last 15 or 20 minutes, so thank you.
And we will, I want to encourage everybody to please fill out the monkey, and we'll send it out to everybody who we know is on the call. But if there are other people in your partnership, if you're in a room together and you know that there's somebody whose name is not on our chat list here or our participant list here, it would be really helpful if you can encourage everybody to fill it out so we can really build the next call around your areas of interest. I'm going to let Rachel have the last word since she's our program officer and with us today.
I want to say thank you to everyone on the call, all the teams that took the time to share kind of what they're working on. Like I said before, it was just so impressive to hear both kind of the level of collaboration and partnership happening, but also the creativity and the barriers that you're tackling. So I think lots to do, obviously. Also just want to thank Mary and Elizabeth and Erica for, keeping us moving and putting together such a great call and format. And then I guess the last thing for me is a quick request, and it relates to the work of the Center for Healthcare Strategies. If there are state policy issues that you're interested in learning more about or that you're concerned about their impact on your community, if you could just email Mary and Elizabeth or whoever, shoot us a quick email with your questions and, things you're interested in learning about so we can work with Alison to get that content to you, as things are unfolding. I know the waiver, the Section 115 waiver conversations are beginning, and so we just want to really, like I said before, create that feedback loop. So thank you again to everybody.
Right. Thank you all. And
great. Thank you.
Come and collaborate.